breast surgery session. We are proud to have with us delegates and senior professors from the United States, from Harvard Medical School, and from Memorial Sloan Kettering, and from the United Kingdom. It's a great honor for us to have them hosting the activities here in Cairo of BGICC for the 8th time. First presentation will be by Professor Mehra from Harvard Medical School, and it will be about is DCIS a cancer and the management strategies in 2016. Welcome to you, Professor.
Thank you very much for the kind introduction and the invitation. Our three moderators, obviously Professor Golshan, who has really brought together an amazing meeting that I first came into about 7 or 8 years ago, and the number of participants, both from the region and around the world, has increased dramatically. And although maybe DCIS is not as common here in MENA countries in the Middle East and North Africa, it is something that will, with increased screening, be more prevalent. And in the United States, and around the world, there's a lot of controversy on how to manage ductal carcinoma in situ. So I'm going to go over two areas, two studies that we did, plus a study that is now open international, actually in the UK, and hopefully then at the end of the session be able to answer some questions. So ductal carcinoma in situ is basically either abnormal cells or cancer cells that are held inside the basement membrane. In the United States, a little over 60,000 cases of ductal carcinoma in situ will be identified each year. There is a very broad spectrum of disease in terms of grade, and low grade versus intermediate versus high grade. And traditionally, surgery has had a role in terms of its management, whether it's lumpectomy alone, lumpectomy with radiation, or mastectomy. And what we wanted to do was to see, is there actually any benefit from surgical therapy, which from a surgeon would sound kind of odd for us to ask this question, and whether there was a little bit of difference based on grade. So this was run by Yasuaki Sagara, who was one of the surgeons from Japan who spent 2 years with me, and through the School of Public Health at Harvard and at the Brigham and Women's and Dana-Farber. We looked at the SEER registry. He presented this as an oral presentation at ASCO, looking at women with diagnosed with ductal carcinoma in situ, whether surgery was performed, yes or no. And because the SEER database has a lot of limitations, we use propensity score in terms of the probability of receiving breast surgery to account for some of the factors that wouldn't be seen in a large data set such as ours. The variables were age, year of diagnosis, race, tumor size, grade, and we looked at breast cancer specific survival versus overall survival based on nuclear grade. And over this time period from 88 to 2011, the SEER registries identified nearly 100,000 patients, but then when we excluded patients that had microinvasion, maybe they had Paget's disease, whether surgery was given or not, maybe was not coded, we had a final cohort of 57,000 patients. And interestingly, looking at reasons why surgery was not performed for ductal carcinoma in situ in that group, there were 500 women in the United States in this time period that did not have surgery performed because the physician didn't recommend it, or the physician recommended but due to unknown reasons, surgery did not occur. And what, as you would expect, those that did not undergo surgery tended to be a little bit older, more likely to be of Black or African American race. If you ended up undergoing surgery, then the grade ended up being a little bit higher. And if surgery was going to be performed, you're more likely to get radiation therapy as those who did not. So with a 72-month follow-up, one good news is that dying of DCIS, no matter what you do to this disease, was very low. It was at 1%. And if you were going to die with another diagnosis, that was much more likely. And if you looked at overall breast cancer specific survival and overall survival, if you looked at the non-surgery group, well, that number was lower, 93% versus 98.5% for those who underwent surgery in terms of breast cancer-specific survival. But when we broke this down by grade, looking at those who had low-grade ductal carcinoma in situ, whether surgery was performed, yes or no, there was no difference statistically. However, those with intermediate and high-grade disease undergoing any form of surgery for ductal carcinoma in situ ended up improving survival. And when we looked at breast cancer-specific survival, again, looking at nuclear grade using propensity, inverse propensity score, those with low grade, whether you did on our univariate or multivariate analysis, there was no difference, but those with intermediate or high grade, there was a difference in terms of survival. And in terms of overall survival, we showed pretty much the same thing. So why did we, what was the benefit of running this study? This was the first study that actually had a large enough population data set to suggest that is there a subgroup of patients that would not benefit from any form of surgery? And again, this is not randomized, it's not prospective, but this will lead to the last quarter of my talk, where we'll talk about some of the trials that are open now nationally, internationally looking at this. So again, this is the first study to examine survival benefit of DCIS by nuclear grade. Because of the imbalances that are seen in these large data sets, we use propensity score to balance them. And of course, limitations with SEER are that there is no data on surgical margins, those that are estrogen receptor positive, which the majority of DCIS is, whether they underwent endocrine therapy, and patient comorbidity. There is some data available of this, but it was really the last half of this study. So what we ended up publishing and concluding was that the survival benefit of breast surgery for low-grade DCIS was smaller. In fact, it was not statistically significant when you did that versus intermediate or high-grade. And that what we suggested was that we suggested a prospective study to look at whether active surveillance or non-surgical management strategies could potentially be offered for DCIS, but specifically for the low-grade population. This means that I need to transition to the second part of my talk. And my second part of my talk is going to focus on the role of radiation therapy for ductal carcinoma in situ. And in the United States, the number of women undergoing radiation therapy for DCIS has steadily progressed over the decades. And there are certainly regional variations in terms of the patients who undergo radiation therapy, depending on where they are in the country. There's also obviously age differences as well. In terms of data on radiation therapy after ductal carcinoma in situ, all the studies, and this is, give this at face, is that radiation therapy is going to reduce local recurrence. And that these local recurrences, which can be significant, and especially in about half of those patients who present with invasive breast cancer, but does radiation therapy actually improve overall survival or breast cancer-specific survival for ductal carcinoma in situ? And I think we didn't have data on this until recently. Looking at the overview data, again, in terms of reduction of events, no matter which trial we looked at, there was a significant reduction in terms of breast cancer recurrence with the use of radiation therapy. But because the numbers of deaths and the populations that they used for those studies were small, they really weren't able to show a difference in overall survival with the use of radiation therapy. And in the United States, the NCCN guidelines suggest that radiation therapy is something that should be discussed with the patient and potentially offered, and those factors would be those who present with larger areas of DCIS higher grade, those where the margins were either close or involved, and in younger patients. But that there may be some patients with lower risk factors where you could consider excision alone. And in the U.S., there has been more work in terms of Oncotype now from invasive breast cancer to ductal carcinoma in situ, and Larry Solon and his group came up with a DCIS score using the ECOG 5194 and the 12 genes assay. They were able to suggest that there is a continuum in terms of risk of recurrence based on having a low, intermediate, or high grade. And I'm really not going to spend any time on this work, although, again, it's something that is of interest. And this is actually the first group that will see this. This is actually we presented this at San Antonio, and this is in press now in JCO. It'll be coming out in the next month, is that we use the patient prognostic score, which I'll go over in a little bit, to see if there's a survival benefit for radiation therapy for ductal carcinoma in situ, again going on to the SEER database. So Yasuaki moved on from surgery to look at, say, is there a benefit in terms of radiation therapy? Again, going on to this SEER database, were there factors where patients who may not benefit from radiation therapy? Again, looking at the SEER registries, we now went from 73 to 2011 and look at radiation coding of beam radiation versus none or patients that refuse. And of these 76,000 patients that we looked at in the United States, and then again, looking at all those exclusion criteria, you cut the number down to 32,000. And just like the last study, we used propensity scoring, probability of receiving radiation therapy, and the variables that are available in SEER, race, tumor size, grade, ERPR, marital status, and which SEER registry that they came from. And we looked at breast cancer specific and overall survival. And as one might expect, that patients that tend to be younger were more likely, and the blue is those that underwent radiation therapy, and red those that did not. Larger areas of ductal carcinoma in situ were more likely to get radiation therapy, and those who were higher grade were more likely to get radiation therapy. And again, kind of confirming what we had shown before is, first of all, breast cancer-specific deaths for ductal carcinoma in situ is extremely low. It's at 1%. But yes, there is a suggestion that there is potentially a survival benefit for giving radiation therapy. But I think, again, the good news is, in terms of the disease process itself, it's very unlikely that the patient is going to die of ductal carcinoma in situ. So when we looked at overall breast cancer mortality with the use of radiation therapy versus not, there was a survival benefit in the radiation therapy group, albeit very small. Even though this is statistically significant, it's by a small amount. And when we used hazard ratios to look at clinical pathologic factors that would suggest a benefit, as might be expected, certain factors, for patients, those with larger areas of DCIs or higher grade, were more likely to benefit from radiation therapy. So we used Smith and Bruce Happy came up with what's called the patient prognosis score. They published this for risk stratification for recurrence in the breast for ductal carcinoma in situ using age, the size of DCIs, and histology. These are factors that are available in the SEER data set. And their original publication was looking at local recurrence. Well, we wanted to use these same prognostic factors, which would be readily available in almost any data set. You don't have to have a lot of information to make this type of decision. And when you looked at those that ended up having a low prognostic score, and again, I'm going to go back just for a second, those tended to be older patients, smaller DCIS, low grade, or maybe having one of these other factors, is that if you had a prognostic score of 0 or 1, your mortality or your survival would be no different whether you receive radiation therapy, yes or no. But we're also one of the first, and I think this is the first publication to suggest that there is a survival benefit if your prognostic score ended up being higher. And you looked at overall survival, overall mortality. Again, those with a low score didn't benefit. However, those with a high score ended up doing it. This category 6, there was just too few patients to make any decisions on this. So what we ended up concluding, and again, this is in press and JCO and should be out the next month, is that our study validates the prognostic score of DCIS, which can be used to predict not only local recurrence, but is there a magnitude of survival benefit for radiation therapy after breast conserving therapy? And I think this is a message that I really would like to push, is that as an oncology community, especially as surgeons, it's very difficult for us to say to operate less. And I think we must be very cognizant of overtreatment of some of the disease processes, specifically ductal carcinoma in situ with a disease process which has a very low mortality. And I think this is a surgeon and I like big knives, so this will kind of move me over to the last part of the talk, is to discuss, well, these were all retrospective studies. How are we going to prove that ductal carcinoma in situ, potentially is there a subgroup that does not need surgery, maybe not need radiation, and can benefit from active surveillance? So Adelaide Francis in the UK was very kind to share the slides on the schemas of their trial of active surveillance for ductal carcinoma in situ. So there's 2 trials that are approved and open in the UK and in mainland Europe is the LORD and LORES trial. And we're going to go over Adelaide Francis's study. So they looked at ductal carcinoma in situ over the age of 46. It was screen detected or incidental microcalcification with no mass lesions clinically or mammographically. They undergo vacuum cystic core biopsy, and if they're low or intermediate grade, they get central pathology review. And those that are considered low risk, again, low or intermediate grade, and all the studies that I did would focus more on the low grade, but they randomized them to surgery versus active surveillance for monitoring. And in terms of surgery, they would get exactly the same type of therapy that you would recommend, whether they went on trial or not, whether it's lumpectomy with radiation mastectomy, and they would be followed by annual mammograms. And those that go into into surveillance and not surgery would be followed by active monitoring with annual mammograms. And their primary endpoint is ipsilateral invasive disease in 5 years. Again, their central pathology review to prove that this is low or intermediate grade ductal carcinoma in situ. Some of the tissue collection variables that are part of this study. One, I think, interesting correlative study that they've done is that there's actually very little information on how microcalcifications that are not treated with surgery, or what is the natural history of following those with ductal carcinoma in situ with microcalcifications progress onto invasive disease. So there's actually a central review of their mammography as well. These are their radiologists who will be looking at their central review. But again, their trial schema is about 1,000 patients. Again, low, what's described as low-risk DCIS. Again, it could be low or intermediate grade, randomizing to whatever form of surgery you would do versus active monitoring. And then these are how you could potentially fall off the active monitoring and the follow-up that happens for 5 and then 10 years. So although I went through a lot very quickly, I'd like to thank you, one, for the privilege of the podium to discuss ductal carcinoma in situ. But I think more importantly is this is a disease process that, at least in the United States and in our patient populations that I see in Boston, potentially in New York and other places, is that there are a lot of women who come in with DCIS that I ended up seeing that end up getting bilateral mastectomies with immediate reconstruction. And if we can show that, one, you're very unlikely to die of this disease process, and there's potentially a subgroup of women where maybe no surgery is necessary, or minimal surgery, or radiation is not necessary, that we can reverse this tide of doing much more rather than less. And this is my son. So I suggest not coming to Boston this time of year, but you're always welcome to come any time of year. But if you do, this is my son helping shovel me out of last winter's blizzards that we had. That's my car under there, and that's him with the shovel. So thank you very much for the podium, and I look forward to answering any questions afterwards. Thank you.
Thank you, Professor. So the questions, I think, will be at the end of the session. So, Professor Said.